this of course, strategies for improved lipid management, but I think it's always a good idea to start with, why? Why do we do any of this? And what are the new cool things that are out there? Because I imagine in the nephrology world, you're like, wow, we have our meds, and then in the lipid space, isn't it just statins? And it isn't. But let's just kind of start with I think this is the ground rules. There's really four statin benefit groups that we think about. Um, there's a fifth that we should consider, and those are just younger folks with really high LDL cholesterol to start with, and really those are familial hypercholesterolemia. But they kind of get seen in one of the four statin benefit groups. It's just not called out really well in terms of age, because we think of older folks like myself, I guess, to consider, doing risk scoring and starting a statin. So we, understand and know the benefits or I'm sorry, how to further risk stratify folks to those statin benefit groups, and then, recognize some of the therapeutic goals. I think 2013 we kind of lost some of those LDL cholesterol goals, and to a degree I'm okay with that, but I'm also not okay with it because it leads to inertia. But then we'll look at the non-statin lipid-lowering therapies and how and when to use these. So I think it's good to start here since, I'm speaking to a mainly nephrology specific group. And so chronic kidney disease and cardiovascular disease, what is the connection? And I think in general, you'll find that it usually leans towards hypertension and diabetes, but there are those with lone CKD. And the question is, ultimately, what is the sequelae? What is the end point here? And most would say, well, dialysis. You all know these data better than I do, but it's not a lot of folks that end up down into the dialysis route. It's like 3%, I think. But they die before that. And 50% of those patients with CKD stage 4 and 5 have the presence of cardiovascular disease. Back in the day when I was at LDS Hospital with our private cardiology group, it was Utah Heart Clinic before they were absorbed into Intermountain. We did a lot of angiograms on folks prior to pancreatic or renal transplants, and I could almost call every single time that we would probably need a stent or bypass before those were done. And then cardiovascular mortality accounts for about 40 to 50% of all deaths. Patients, when they're having a death, 40 to 50% of the time, it's from a cardiovascular death. And so I think this is important to look at as we kind of view annual mortality. And look at this. This is, age 25, 34. So I'm going to bring this figure data in. But 25 to 34-year-old patients with end-stage kidney disease, look at this is them, not down here where, you should live long lives until you, of course, as you get closer to our average lifespan, these are the mortality rates. But look what mortality rate is when you start with, end-stage renal disease or CKD at earlier ages. I mean, you're just essentially equal to an 85-year-old in terms of your annual mortality rate. So that's kind of scary. So let's come back to lipids then. I want to use this analogy because this is what I use with my patients. I say, look, you're worried about cardiovascular disease, you're worried about plaque, when to use certain therapies and like aspirin and statins, etc. And I'd say, look, you can't have a car accident unless you have cars, but not all cars cause accidents, right? Here we okay, construction, etc. People are doing okay, but some cars do cause accidents. And so, yay, congratulations, car crash. So it's important to recognize that just because you have a kidney doesn't mean you're going to have kidney disease, but you're going to have a kidney to have kidney disease, just like you have to be alive to die. So how does this work, though? What I mean by that is LDL cholesterol, not all of them are atherogenic. This is an important concept. So just because you have this LDL cholesterol of 180, 190, 200, 250, that's really high, by the way. It doesn't mean you're absolutely going to have a coronary event. So as we kind of think about this, it's not the large LDL cholesterols, it's the small LDL cholesterols that are small enough to be able to get through the endothelial cells and to the back side of them where they develop plaque. So just recall that you cannot build atherosclerosis in the center of the lumen. It actually builds up underneath that endothelial layer, and this is where it gets oxidized and starts to build plaque. Okay, but it's small. It has to be small enough to cross through that barrier. And we have LDL cholesterol, and we could talk about LP little a, lipoprotein A, which is essentially almost the same size and shape as LDL cholesterol, just has an extra ApoA tail to it. But again, kind of thinking through this is kind of busy. But if you think of the endothelial layer right here, this is the blood plasma, and where the LDL, VLDLs, I mean, they show one coming through here, but essentially it's too big to kind of be transcytosed through that endothelial lining. But it's the smaller ones really that come through, and then there's reactive oxygen species that get it. It starts to build this. The macrophages get in there, and then you get this crystallization and plaque that occurs. So not all LDL cholesterols, just like not all cars, have accidents or create accidents. So but because the potential exists for crashes or atherosclerosis, right? This is, I mean, in the end, this is what's happening is that plaque is potentially building underneath that endothelial layer. And then, of course, in any type of traffic situation, you might find that there's car accidents. We have post limits. We want to, try to reduce and mitigate any of these crashes, any of these problems. And so from the car side of things, we have speed limits, but on the cardiovascular side with lipids, we then post limits as well. And we think of, look, if you have clinical ASCVD, you've had a heart attack, stroke, peripheral arterial disease, you have, carotid disease or anywhere else, then you want to post limits and say LDL cholesterol should drop below 70, but very high risk individuals here where they've had multiple events or one event and multiple risk factors, then you also want to limit it further down to less than 55. So, but the one thing I want to let you know is that while we're targeting these and posting speed limits and LDL cholesterol goals, actual normal physiology for LDL cholesterol, the most you ever really need is between 20 and 40 milligrams per deciliter. That's, it's our diets. We're really we have access to high caloric and calorie dense foods. And so we kind of accept up to 100, 130 milligrams per deciliter, but true normal is between 20 and 40. So ASCVD, this is kind of what we think, right? We're like, yes, none shall pass. We do a great job, and we're limiting it. We're somehow reducing it, and really, this is how cardiovascular disease sees us, kind of a little ineffectual. Um, are you really doing anything? And I think part of this is just inertia. And the other part is we just need to level up our knowledge in this space and what we can do to reduce risk. So just quick epidemiology as we think about this across the United States, there's an MI about every 40 seconds. We've talked about this, I think, previously. It's almost nearly 1 million folks a year have a cardiovascular event. And it's about a third of those are new events. The rest are recurrent. Here, 50% of the US population is 340 million people. Half of them are greater than or equal to 40 years of age. And so here's where the events kind of pop in for 170 million men and women and the event rates here. Okay, so I said about 1 million. It's about 805,000. Depends on the statistics that you're looking at. But I think a great one is going to they update it every year from AHA is the currently 2024 heart disease and stroke statistics. Okay, so why lower lipids? What's the evidence? As we think about this, I want you to look at this graph because it's better to think of cumulative cholesterol years. And when we think about cumulative cholesterol years, this is the threshold for events. And I've added in ages, 20 years of age, 30 years of age, 50 years of age. You'd say, well, okay, what does that mean? Well, someone that has homozygous FH, where they have two mutations, inherited one from each patient, and LDL, remember, I said normal is 20 to 40, but this is 10 times that or more at 500 milligrams per deciliter. Look at their events. And this is exactly what we see. These are folks having strokes and heart attacks in their mid-20s. They are developing xanthelasmas around their eyes, these lipid plaque depositions. They have arcus. They're building tendon xanthomas where plaque builds up on their hands, their tendons, etc. Then when you move over to LDL cholesterol greater than or equal to 190, it can be heterozygous FH, where they have one of the known mutations, or it's polygenic. There's kind of multiple hits in their DNA that leads to this elevated LDL cholesterol. And they're having events in their mid 30s to 40s. And I treat many of these folks, but unfortunately find them after they have an event, and luckily they survive it. And these are kind of the rest of us, right? As we get to like average age of men, having an event is about 55 or higher, and then women, it's about 70 or older that we're looking at event rates. And so, if you can kind of bend the curve, so to speak, all of us have lived through the COVID era, and LDL cholesterols, if you can keep them low and appropriate, then it reduces the risk. I hate the word prevention because just like death and taxes, it's going to happen. It's just how soon will it happen? So as we kind of think of FH, then these are males that have FH and have been untreated. Their levels of LDL cholesterol is greater than or equal to 190. By age 50, half of them will have had an event. In contrast, in the regular population, that's 6% will have an event versus 50%. And then in the women population, it's 30% will have an event by age 60. And to normalize that in level set, in the regular population, it's about 5%. So you have, a 10-time risk here if you have FH untreated, and you have about a 6-time risk here in women if they're untreated and have familial hypercholesterolemia. So think about that burden in cholesterol years. It's just an excessive amount of supply to develop plaque. And then what about the other risk factors? I mean, this applies to you as well as me in terms of strictly cardiovascular or chronic kidney disease, but look at, the impact of all the different risk factors for cardiovascular disease. And these are all the risks combined. But in the end, lipids still, if you impact lipids, then you are going to reduce risk, even in the setting of folks that are, diabetic, hypertensive, etc. Lipids is an important part because that's the ultimate kind of factor that gets into the endothelial layer and develops plaque. So then, what's the evidence and where have we built it for statins? This is great. This comes back to 2005, and I was there at the Treating to New Targets late breaker at ACC in 2005, and it was just kind of really neat to be there in the audience. But look at 4S. This is the one that you think of simvastatin, right? LDL cholesterol of 190. Arguably, these were like FH folks. And we didn't have any treatment, so they just chose like the highest risk individuals and said, well, if we start with a statin, simvastatin, what will happen? And it dropped them down to about 115. But look at the risk reduction here, okay, if you were to kind of rise over run. And then subsequently, each study with statins, lower, better, lower, better, lower, better. And this is out to 75. That's 2005. 10 years later, 2015 is reported out the Fourier study with, PCSK9 inhibitors, and we find those people are down in the 29, 30 milligrams per deciliter. Do we see benefit? Yes. So there's not really a bottom end to benefit, but as this is a statin slide, the question was, is statin versus no statin? For every 38 milligrams per deciliter that you drop LDL cholesterol, you get about a 20% reduction in major adverse cardiovascular events just in the first year. And then hopefully you keep people on a statin, and that risk reduction kind of accumulates in terms of protection. And then they said, well, okay, statin versus no statins. Well, we better keep people on a statin. But what about more intensive statin versus less intensive? And again, what you saw is it leads to better protection. And then ultimately, this kind of led to our current guidelines, which is really, even though here is milligrams per deciliter, what I'll show you is that the first goal out of the gate is a greater than 50% reduction from baseline, whether that's 100 and dropping to 50 or 200 and dropping to 100, there's always benefit. We can see that along this risk reduction line here. Okay, so Remember, though, that there's residual risk after statins. In every single one of these trials, the circled group here is what the event reduction was. And each time it's about 20 to 30% risk reduction. But I tell my patients, statins aren't magical. People on statins had events. They just happen to have 30 to 40% less events. So there's still a residual risk. There are other things we have to manage. But if you're not starting at least with a statin and treating lipids, I think you leave your patients quite exposed. But just recognize they're not magical, and I make sure my patients know, yes, you have a story of a family member that's on a statin had an event. I get it, and that's certainly true. Okay, so then, yeah, still means events are occurring. But so, what are the strategies for lipid management? Um, I think of this as, are we working blindfolded or not knowing, right? It's never a very good strategy. And sorry, this gift started right at the end, but this is kind of like not doing lipids. Yeah, you're kind of running a race without knowing what you're treating and where you're going. So, hopefully what this slide tells you is we should repeat a lipid profile. We should get a baseline and then see where they go. Because otherwise, yeah, things happen. Um, and we're probably not getting them to goal. So, how do you calculate the risk for an atherosclerotic cardiovascular disease event? This is MI, stroke, PAD, and really, this is kind of where it falls out: is high risk primary prevention. These are folks that have no prior cardiovascular event versus over on this side where they've had a cardiovascular event. So, here are the kind of the risk groups. Actually, these are the four statin benefit groups. This is one group. If you've had a cardiovascular event, and again, not coronary event, I said cardiovascular, so it can happen in the brain and in the legs and in the torso, just systemic. And then these are the three primary prevention folks. So baseline LDL cholesterol is greater than or equal to 190, and then if you have diabetes 1 or 2, aged 40 to 75, and then just age 40 to 75 without diabetes and not cardiovascular events, then you start doing risk scoring. So, excuse me. Let's. I have, you'll have these slides. I'll provide them to you. But really, what I was doing there is just kind of showing the ASCVD group and how easy it is to calculate, which is just basically everyone with a single event, and it's greater than 12 months ago. The very high risk group is everyone that we treat, really. They've had either one event and greater than two risk factors. You probably treat diabetic patients, and they have hypertension. And by the way, CKD is its own risk factor. And then they've had an event. So most of your patients are very high risk. Most of my patients are very high risk. Some are not at very high risk. And then we have, of course, we share a bunch of primary prevention patients. So then as you get to what is the goal LDL cholesterol, these are really kind of meant to be summary slides that you can come back to later. But essentially, for any one of these in the primary prevention group, you're looking at greater than 50% reduction from baseline and shooting for an LDL cholesterol less than 100. So first, try to get a 50% reduction, but if they're at 200, they'll drop just to 100, and you'll still want to add something to get them less than 100. Same thing here with type 1 and 2 diabetes. Your goal is really to get them less than 100. And then here with ASCVD risk score, if you do the 10-year risk score, then less than 100. However, these folks here in the greater than or equal to 20% in 10 years. So let me just level set that when you've had a heart attack, that's kind of your event rate. Is you're likely about 20% or more likely to have another event in the next 10 years. So when you do an ASCVD risk score and they're at greater than or equal to 20%, you're saying they're equivalent to having had a heart attack already. And so we treat them the same way, 50% reduction, and try to get their LDL cholesterol less than 70. So here on the ASCVD side, when they're not at very high risk, but they've had an event, then you can see it's very equal here because those folks have at least 20% in the next 10 years. But when you get to very high risk ASCVD, this is where you want a reduction from baseline, but try to achieve an LDL less than 55. So it's the only one that's this strict in terms of trying to get folks down low. And then the rest of them, you can kind of see less than 100, less than 70. Okay. But to me, the real first question is what is LDL cholesterol, when and how often should it be measured? Because again, you're just running in the dark, putting blindfolds on and running the race. Or rather, it's not you, it's the patient's life. So, we're just part of that process. The American Academy of Pediatrics really recommends first lipid screening just after 2 years of age, but no later than 10. So really, when you're, being seen in the pediatric office, you should get a lipid at some point. Um, and then here in the 2018 guidelines, it's adults greater than or equal to 20, not on lipid therapy. They should get at least a screening. And then for those that are on therapy, you should, repeat a lipid measurement from 4 to 12 weeks after you either start it or dose adjust. And then from there, I'm usually at the annual um, for repeating lipids once I've got them dose adjusted. Okay, so here are the statin benefit groups. We kind of touched on them in the prior slides. ASCVD, again, those break out to not at high risk and then very high risk. Then you've got the kind of the familial hypercholesterolemia group, the diabetic group, and then the not diabetic group that happens to be 40 to 75. Okay. Um, I always have to laugh because my wife thinks that there's a difference when I throw a child up and what I think, to not throw them up, but maybe you're tossing them up in the air and playing. What I think is okay versus what she thinks is okay. So this is kind of the meme, right? Men, we kind of think, oh yeah, that's okay, and then this is kind of like maybe grandma or aunt or whatever, and this is mom, like, what are you doing? Quit throwing my child up in the air. But this is the difference between lower risk versus not at very high risk, but kind of risky, and then very high risk ASCVD. Okay, so not at very high risk and very high risk. Remember, we're looking at ASCVD, and the column on your left, the top are the ASCVD events that count toward it, and then the risk conditions that will then be part of the 2 or more. This is not at very high risk ASCVD. Okay, so you've had one ASCVD event, plus or one or less high risk conditions. And so here's an example. They had an NSTEMI in 2018. Maybe they have hypertension. Just that's it. That's all you're managing. And you're like, right? Like I've ever seen a patient with just that. Stroke 2014 and diabetes type 2. So I would say this is the unicorn. Whereas the second group is really where most of our patients are, the very high risk ASCVD. These are folks that have had more than one event for ASCVD, or one event, one really recent ACS event, like they just had a heart attack a month ago, and or ASCVD event with greater than or equal to 2 high risk conditions. And this is probably more our cup of tea, where we've had folks that have either had sorry, this was I gave this in like January, I think, of 2023. So it was a recent event there. But STEMI, then NSTEMI, a little over a decade later, that's very high risk. They've shown that they will have another event. Here is a stroke with 2 or more risk factors. So again, I think most of our patients fall into this category of very high risk ASCVD if they've had an ASCVD event. Let's come back to then treatment goals. So this is not at very high risk. Again, I give the examples here. Maybe they had an NSTEMI, they have hypertension. They've had a stroke, they have type 2 diabetes. And again, I think these are the unicorns, but this is the treatment goal, greater than 50% reduction, and then LDL cholesterol of less than 70. Most of my patients, and probably most of yours, fall into the very high risk ASCVD category, where they've had more than one event, or they've had one event and they don't just have diabetes. They have, well, you're seeing CKD, and they probably have hypertension, and or they're 65 and older. So, greater than 50% reduction, and then an LDL cholesterol goal of less than 55. Now, we throw non-HDL in here. That's a kind of a conversation for a different day, but we can talk about what that means in relation to all lipoproteins. But LDL cholesterol goal of less than 55. Okay, so the next group, hopefully that makes sense here. We're just talking about LDL cholesterol goals, and then you should start with a statin. We'll talk about non-statins later. So LDL cholesterol greater than or equal to 190. These are folks that you have a suspicion they either have a genetic mutation or polygenic mutation, but their LDL cholesterol baseline is greater than or equal to 190. And how do we derive that LDL cholesterol? Just remember, they're rarely a direct measurement unless they have a triglyceride greater than or equal to 400. And then our central lab will reflex to a direct LDL cholesterol measurement. Otherwise, what happens is actually you're placing in total cholesterol, triglycerides, and HDL, and that's how you derive your LDL cholesterol number. It's a calculated number. It is not a direct measurement unless it specifically says direct LDL, and usually that's after triglycerides greater than 400. So coming back to this, you've seen it. It's this group right there, moderate hypercholesterolemia, and their goal is really maximally tolerated statin therapy and then adding other things to it to get an LDL cholesterol of less than 100. So here are your treatment goals. Okay. So 40 to 75 years of age and diabetes. Do we treat with statins under 40? Yes, we do. And that's one of those nuances that's kind of lost in these benefit groups. But if you want to read the 100+ page guidelines, you can. I would just say, honestly, a conversation for statins should be had in all type 1, type 2 diabetics. So here, baseline risk is, basically diabetes. And it's kind of an easy button. You really just start with a moderate intensity statin. If you don't want to do any thinking at all, and that's okay in our busy lives to a degree, this is someone that has type 1 or type 2, you can just throw a moderate intensity statin on there. But here, you can then say, what are the risk enhancers that might make me think they need high intensity statin? Well, these are the risk enhancers. So a longer duration, greater than 10 years for type 2, greater than 20 for type 1. Albuminuria, if you're doing a UACR, which this group does so many more than I do, but I have been doing them. And then EGFR less than 60, retinopathy, neuropathy, ABI, which I would argue is ASCVD. They have peripheral arterial disease. And then next level risk stratification, age. So men greater than 50, greater than 60 for women, and type 2 or type 1 diabetes. And then you can assess whether these risk enhancers are present. The risk calculator you can do if you want to. You don't actually have to do the ASCVD risk calculator in folks with diabetes because you're just going to start with moderate intensity statin anyways. But if you do, and they happen to be greater than 20% on a 10-year risk score, then high intensity statin is where you're going. Okay, then the last group. These are those without diabetes and happen to be in probably our age group, 40 to 75, although some of you are probably younger than 40. And I don't think anyone's over 75. So here's the question is, are they statin eligible? So this is the ASCVD 10-year risk score. I haven't updated this to the most recent scoring, which is called the PREVENT. It's the American Heart Association did this kind of on their own. This was a multi-society risk score here that the ACC let out on, but AHA kind of updated it. And the only difference, well, there's a few differences, but the main two differences is they add BMI to this and EGFR. So you'll be happy to hear that as you're, dealing with kidneys, and the rest of us have been a little behind. But it helps us to kind of think, okay, EGFR and then BMI, and you're adding that to this. There's different weightings that are on there for the parameters here. But in essence, these are the things that you need to gather at any visit. So BMI as well and EGFR in order to do a risk score. So let's just kind of look at this. So you have a 40 to 75-year-old gentleman, 54, no history of diabetes, or smoking or hypercholesterolemia. He has hypertension with blood pressure 130 over 90 and a family history of premature coronary disease. So it was really his 55-year-old brother, 1 year old brother, that 1 year older brother that received the stent to the proximal LAD this year. And he's like, oh crap, what about me? So you kind of see his total cholesterol 180, LDL cholesterol is 108, HDL is 40. And when you put it into the risk score, what ends up is he's kind of in this borderline. He's not 7.5 or greater. That's where we recommend. It's not consider. We recommend statins when they hit the 7.5%. But he's borderline. And so you might say, well, you don't have to be on a statin per se, at least by guideline, but it's a shared decision-making process. And there are other things we can do to help sort him out. So as we kind of put him in, here he was 50. Oh, whoops, I'm pointing with my finger now. 54, male, white, blood pressure 130 over 90. We had his total, his HDL, his LDL, and then no history of diabetes. He was never a smoker. He is on antihypertensive treatment, no statin, no aspirin therapy. And then you'll see up at the top, it'll calculate it. And he was 6.6%. So, what do you do with this borderline risk individual? You look at risk enhancers for consideration of moderate intensity. So, does he have a family history of premature ASCVD? Well, he's on the border. Brother was 55. Here it says less than 55. So I still, kind of pucker up a little bit and go, ooh, I don't know. You're 54. So then you can look at what, does he have primary hypercholesterolemia? No, his cholesterol's 108. Does he have CKD? We don't have that information. So that's probably something we should get. Metabolic syndrome, again, with regards to a basic metabolic panel, if he's fasting, great. Get an A1C as well. And then obviously the female history does not apply to him. And then here are the other lipid markers. I get an HS-CRP. I get an LP(a) once. I do get an elevated, I do get an ApoB. The thing that I don't do as well at, and it's ironic and I feel a little silly and it's a little shameful, but I give a talk on PAD, right? You heard it last week. I don't do enough ABIs, and he definitely fits the group that you should do an ABI on. Okay, so we're just going to move to another person that the only thing I've changed is this person smokes. That's it. Everything else, all the other parameters were the same, and it bumps him to that zone of 7.5 to less than 20%. So now he is what we consider, and as you put it again, you can see I didn't do anything but change the smoker, and that put him at 12.6. It almost doubled his risk. That's how weighty smoking is with regards to cardiovascular risk, if you were wondering. That's the only parameter we changed. 6.6, basically doubled it to 12.6. Okay. So he falls in this intermediate risk, and that's where it says, look for enhancers, but actually moderate intensity statins are recommended. The question is, do you, if the patient decides, we're having a shared decision-making process, they're like, I don't want to be on statin. Well, let's see, what else is going on? Well, family history of premature ASCVD. You came to me, what do you feel? In the least, we should stop your smoking or help you there, because you're double the risk of the last patient I saw. And then you could order these same risk-enhancing factors. Okay, so what about a coronary calcium score? Why not? Some of you know that I'm one of the sub-investigators of CoreCal. That's a study that's now been probably in its 5th year, but we're trying to enroll 9,000 patients. We're around mid 5,000. But what is a coronary calcium score? How does it help? Well, here, this is what we're looking for is CT scan. It's basically the same as a mammogram in terms of radiation. It's about 1 millisievert. And we're looking in the space here. This is the aorta, and this is left main, left anterior descending, left circumflex. And you can see in moderate calcification, they start to get this calcium. And then in severe calcification, we can see that there's quite a bit of atherosclerosis that's going on. But don't take my word for it. Let's look at this thing right here. So when you're looking at a coronary artery in cross section, this is the endothelial lining, and you might have some macrophages, foam cells. But even with calcium zero, folks, calcium zero, you can still have some soft lipid buildup here. And in fact, about 1 in 100 people with calcium zero can have up to 50% obstruction inside that artery without any calcium. But I would say that there's something about calcification that tells me about injury. And even when you look at 15 years of follow-up data after calcium zero, the event rate is about 1%. Okay. And you'd say, well, 1% is 100% for the person that has an event. Yes, I get it. But in over 6,000 people, where a whole bunch of them have CAC zero and the event rate is 1%, I'll take it over the 20% that happens as you go here and you get calcium, and especially when you get into the greater than 100 or 75th percentile. Those are folks that now have an equal event rate as someone that just had a STEMI. Okay, calcium zero, you may be able to consider withholding statins, although I feel uncomfortable in doing so in folks that have diagnosed familial hypercholesterolemia. So I never recommend to stop it, but rather it's a guide for intensification of therapies. For 1 to 99, favor statins because guess what? You have known atherosclerosis. And then greater than or equal to 100, it's indicated. Okay, it's indicated statin therapy in the least. So as we look at this last gentleman, again, I've not changed much of anything other than I kept smoking. So we went from 6.6 to 12.6%. And then I added a little difference here in total cholesterol, and I dropped his HDL a little bit, and it put him in the 20% or greater event rate. Okay, so I just wanted you to kind of see the progression with very few parameter changes of what goes from borderline to intermediate to now high risk. And so these folks right here, their event rate is equal to, epidemiologically and statistically, their event rate is equal to someone that's had a heart attack already. So we look at high intensity statins. We know it's greater than 50% reduction, first goal. And then the second goal would be to get to less than 70. But these are it. This is your choice for high intensity statin is Atorva 40 and 80 and Rasuva 20 and 40. Okay. Now we've gone through the LDL cholesterol, the what's, the when's, the how, the who, the why, the risks, etc. Now what do we do? Because statins aren't the only thing, and I've talked to you about residual risk. Even when you use statins, people still have events. They just have 20 to 30% less events in that group that's treated. So how do we get there? How do we get to lowering risk? Here, I'd say, look, statins kind of your bulwark. And then we have the PCSK9 interfering drugs. These are injectables, although they're working on oral. And then here's bempedoic acid. Some of you might have seen the recent trial last year, the CLEAR Outcome study. And then we have ezetimibe, kind of a tried and true therapy as well. That's been out half as long as statins, but that's still 20, 25 years. So let's do this. So statins first. Again, the high intensity statin group, the reason why it's called high intensity statin is that the estimation of LDL cholesterol lowering is at least 50% or greater. Moderate is 30 to 49, and then low intensity is less than 30. And I do this with my patients. I do back in the napkin calculations, and it's fun because they're like, wow, how did you know it was going to be that number? And it just gives them a roadmap. And I say, well, we know the data, the PK, PD data on pharmacokinetics, pharmacodynamics on what these drugs do and how they impact LDL cholesterol level. So these are the groups that you would use a high intensity statin. So I've given you the easy slide button. Okay, so here's an example. A 35-year-old woman who presents with for annual checkup. She's physically active and follows a plant-based diet. Her family history is concerning for both her mother and a maternal aunt with MI in their late 40s. Arguably, this starts to get my flags up, and I say, well, these are early premature events. And then you get the lipid profile, and you're like, wow, total cholesterol 300, HDL 40, triglycerides 80, LDL 244. And so in my practice, we do genetic testing to confirm this, although a quote unquote negative genetic test does not mean it's uh, not inherited. I know, double negatives. It is inherited, but there's a polygenic component as well. We just know of 4 mutations and we test for them. But having the absence of those mutations does not mean it's not genetic. So here, what I do is I do the back of the napkin calculation with her. And remember, this is a high intensity statin. She fits into the high intensity statin group. But at 244, you are not getting less than 100. You're just not on a statin. And so this is the estimated LDL cholesterol that she'll achieve on atorvastatin 80 or rosuvastatin 40. So based on the discussion of risk, then I we've decided with her to go with rosuvastatin 40, and I didn't mean this should have been animated to not show up until just now, but this is the back of the napkin calculation. And so it helps me because I say, I start with the disease, I start with the process, I start with the goals, and then I say, this is what the therapy probably will do. And the usual question is wait, so if I'm going to stay above goal, don't I need something else too? And that helps lead to talking about ezetimibe or talking about a PCSK9 inhibitor. That way, I'm not forcing therapy down their throats, but rather helping them to understand, okay, what's the next logical question? Uh, and so she's still above the 100 milligram per deciliter threshold. How do we get there, right? So this is a nice slide that goes through the different mechanisms of where bempedoic is. This is ezetimibe. That's actually part of the colon, not a weird looking nipple thing. And then inclisiran and PCSK9 are on this side for PCSK9 protein. Yeah, I don't know why they drew it that way, but anyways, so these are the non-statins, LDL cholesterol lowering agents, and what you would estimate a reduction would be if you deploy these therapies, because we know what their mechanisms are. They shouldn't be used as like, I don't want a statin, so I should be on this. There are fundamental mechanisms with statins that we use. It's not just for LDL cholesterol lowering. And I didn't get into that here with you, but just know that all of these, except for bempedoic acid, have all been studied as add-ons to statin. These are further reductions in events when they had a statin on board. But it doesn't take away that we saw these further reductions in LDL cholesterol. So ezetimibe, bempedoic acid, alirocumab, evolocumab are the monoclonal antibodies that you inject every 2 weeks. Inclisiran's I shouldn't say newer, but it is FDA approved newly in the United States 2 years ago. And this is an RNA inhibitor, which you do twice a year instead of every 2 weeks. But these are the cardiovascular outcome trials that you should think about and look at, and what they led to in terms of reduction of risk for each of these. So yes, further LDL cholesterol lowering, it does reduce risk, but how you do it also makes a difference. And you can see that between the further risk reduction that happens when you add these other therapies. You would say, wow, an extra 60% reduction of cholesterol. Shouldn't that be like a massive relative risk reduction? And I'd say, yeah, in general, we'd say yes, it's about 15%, not an additional 20 to 30%. Okay, so ezetimibe, it's a Niemann-Pick C1L1 receptor inhibitor. So what it does is it decreases the cholesterol uptake. This is first-time absorption. If you eat foods, regardless of whether it's a super fatty meal or plant-based, you still have some fats that are in your diet that get emulsified by bile, and then we try to absorb it into the gut through the colon. And ezetimibe blocks that. I kind of think of it as the bouncer at the bar that says, you know what? I don't want you to come in. I checked your ID, get out. And so that's kind of ezetimibe for that first group. But reabsorption also occurs. We're very, very efficient animals, or mammals, whatever, where that bile acid, we reabsorb those components to reuse them again. And so again, it's that bouncer. We, kicked out the drunk and said, look, you're outside the bar for a reason. Don't come back in. So first time absorption and then reabsorption blocks both of those. And then typically we have a further reduction by about 18 to 20%. Again, it's been around since 2002, and it's only 10 milligrams. You can cut it in half, I guess, but really it's meant to be a one single dose or singular dose strength. So we go back to her and we say, okay, you're at 122 on rosuvastatin 40, and then what are we going to do? We're going to add ezetimibe. And in fact, in so doing, I chose the lower end at 18%, and you times that by her 122, and you minus that, and you get to just about 100 milligrams per deciliter. And if you're both happy there, fine, don't do anything else. And if you decide to do anything further, then you're adding on therapies. So here, though, we decided that, gosh, that's not less than 100. You're still at 100. So let's talk about this. What's next? We decided PCSK9 interfering therapy, and this, there's the monoclonals, there's small interfering RNA. Now, the reason why this is important is because PCSK9 is a protein that sticks to another protein receptor that's very important. It's called LDL receptor. And just like its name, it receives LDL cholesterol from the bloodstream, takes it into the liver, and disintegrates it, gets it to go away. And so it's the garbage truck, right? It comes out, picks up the garbage LDL cholesterol, brings it in, gets rid of it. But PCSK9 is kind of like your overbearing manager that says, let me see what you're doing there, Fred. Gets on the garbage truck, goes out. Fred picks up the garbage, takes it to the landfill. He says, oh, that's great, you're fired. Okay, so if we can inhibit this overbearing manager protein, then it allows LDL receptor to be more effective. And in fact, that's exactly what happens. You get a 50% increase in reduction of LDL cholesterol when you use these proteins to inhibit the monoclonal antibodies to inhibit PCSK9. Now, that's just the Repatha, Praluent, or evolocumab, alirocumab. And so that's what we decide. So on rosuvastatin 40, ezetimibe 10, she's right at 100. We go ahead and decide on evolocumab, which is 140 milligrams twice a month. So she just uses this EpiPen type pen injectable and puts it up against her thigh or her abdomen. Click. It's a very small gauge needle, so it takes about 10 seconds to deliver the therapy. And lo and behold, it reduces her cholesterol by about 50%, down to 50 milligrams per deciliter. She's happy, I'm happy, we're happy. Okay, so what about statin intolerance? That should have been the first thing out of the gate, right? Because you're like, most of my patients are always telling me about statin intolerance. It exists. It really does exist. And I think there are folks that have complete intolerance. I've actually been like 4 or 5 statins in, including retrialing something like pitavastatin, and they just can't. So I have FA patients that unfortunately don't have access to one of the better therapies because they just can't tolerate it. But then there's partially intolerant folks that their maximum dose is like 5 milligrams of rosuvastatin every third day. I'll take it. But at least they're able to, use an intermittent dose. And then I've tried, usually I get to pitavastatin, which y'all have probably heard as Livalo. There's a Zypitamag as well. But it's very well tolerated. Then there's the nocebo effect, where you tell them, hey, you might experience these things. So they do, regardless of whether they're on placebo or not. So they trialed this. What happened was, not what happened, but they did what's called the SAMSON, SAMSON, N of 1 trial. And it was a year-long trial where 3 months, 4 3-month periods, one in which there was nothing given, one in which there was statins given, one in which placebo was given. And then what was I'm trying to remember what the last one was. Anyways, as they went through, of course, no one had any complaints with the 3 months of nothing. They didn't know whether they were getting placebo or statins. But in the end, when they got back the surveys, 90% of the folks had at least as many symptoms on placebo as they had on statins for 3 months of placebo. And when you showed them the data of what they experienced, about 50% of them decided to restart a statin, recognizing that it was partly just not in their head, but yes, partially they were affected by this nocebo effect. Okay, so this is the clear outcome study for bempedoic acid. You might hear its brand as Nexletol. They have a dual Nexlizet, which is bempedoic acid and ezetimibe. But the clear outcomes trial was nice. I mean, they looked at both primary and secondary prevention, so high-risk folks and then folks with cardiovascular disease. And as they ran the trial going forward, it kind of looks like it lays on itself here where there's no difference. But there was about a 13% risk reduction in a 4-component MACE from placebo to bempedoic acid. So it just tells you that none of these therapies are magical, but what we want to see is in large groups of people a certain reduction in risk in that population. And so the other interesting part was these were statin intolerant folks. They were either unwilling to try a second statin, or they were fully statin intolerant, or they just had a very low dose statin. So about 1 in 4 had, like I said, like rosuvastatin 5 every other day or whatever. Okay. So that was bempedoic acid. And it falls along the same assembly line as where statins do. Statins affect the HMG-CoA reductase enzyme that allows cholesterol to move forward. So it inhibits that. But bempedoic acid is a little bit earlier on, and it only is activated in the liver. That's it. So it's not active in muscle tissue. And so when you go back to the bempedoic or the clear outcomes trial and other bempedoic trials, placebo and bempedoic acid myalgias, exactly the same. So if you were going to experience it on bempedoic, you were probably going to experience it on placebo, but fascinating, they were low in both ends. Okay, so it's a great medication. However, because it sits along the same chain, if you're on a statin, it's less effective, about 15% reduction in LDL cholesterol. But if it's by itself in the statin intolerance, it's about 25% reduction. But if you combine it with ezetimibe, then you're close to high intensity statin. Okay, so we have a 50-year-old man who presents with for annual checkup. His hypertension's under control. He's on losartan. He's on dapagliflozin, metformin, moderately active, does not smoke, has no family history of ASCVD, trialed and experienced myalgias on 3 different statins, including low dose, torvastatin, rosuvastatin, finally pravastatin. He's not taken any for over a year. So we get his profile back, and his LDL cholesterol is 138. So here, we had decided, okay, we'll do bempedoic acid as an oral pill. And without a statin, it's about 25% reduction. It gets him to about 104. Remember, he's diabetic, he's 50, so his actual goal is to go less than 100. So the decision is, well, gosh, there's this combo pill with bempedoic and ezetimibe. And so that's kind of the thought process here. From 104, we decide to go on that combination pill. It's 180/10, and then we get that additional 20% reduction, and he's at 85 milligrams per deciliter. So it's a great therapy, and they cost the same. Nexletol and Nexlizet are the same. You have one less pill to take, so it's fantastic. And then here's inclisiran. So inclisiran, same thing. It affects PCSK9 and the protein, but instead of interfering with the boss who's already kind of in your workspace, this is kind of like going up to whatever MBA school of crappy bosses and saying, quit graduating these crappy bosses for about the next 6 months. And that's kind of what happens here with inclisiran and how it affects the messenger RNA, and it decreases the graduation of these crappy bosses. And in doing so, for about 6 months, you'll have a 50% drop in LDL cholesterol. We inject that in clinic, and so it's great for Medicare patients with Part B benefits, because all of them do. Not all of them have the same Part D benefits, D as in dog. And so it's a great therapy for them, but we administer it. And that's baseline 3 months, and then it's every 6 months after that. So you have to kind of ramp it up. So here's a 67-year-old woman with a history of remote MI, optimized diabetes type 2 and hypertension. Sounds like she's very high risk. She's on rosuvastatin 40, ezetimibe 10, alirocumab 150. So she's already on triple therapy. However, she reports she's had a hard time remembering to refrigerate her alirocumab because you have to refrigerate it and you have to pull it out every 2 weeks. But she travels often between her children who live in different states, and she's left her alirocumab at either at home or at children's homes. And this is kind of expensive. It's $6,000 a year to be kind of leaving it around. And then she's been off her alirocumab for 4 weeks. So high intent, or excuse me, very high risk. LDL should be less than 55. She's at 87. Really, she's washed out of her alirocumab. So you want to get her to less than 55. So you both decide on switching from the monoclonal antibody to the small interfering RNA, inclisiran, and in doing so, you've got her LDL cholesterol down to 43 milligrams per deciliter. And then she just times her visits with you for injections, or on those off times that she's not able to get in, then she can, the MA, and that's how I set it up. They do the injections, and then she just gets charged a MA injection fee, $15. Okay, so here's the summary for the 4 statin benefit groups. This is the slide that you can print and just put up if you want to. But ASCVD, for those that are not at very high risk, then these are their goals. Very high risk, it drops to less than 55. But most everyone else is kind of at the less than 100. Whether it's moderate intensity, high intensity, etc. Those are kind of the goals. And then for folks in the high intensity, of course, you want a greater than 50% reduction and probably head towards 70 milligrams per deciliter on their LDL cholesterol. Here are the strategies for improved lipid management in summary. Define the risk. That's define it for the patient, define it for yourself, know what you're treating in terms of risk, obtain a lipid profile. Don't go blind, don't be putting on a blindfold and running down the road. Know where you're starting from and know where you're going. Repeat the lipid profile at least in any dose changes and initiation, and then annually. Start with the statins, discuss statin intolerance, nocebo, be okay with reducing from, just because it says high intensity statin in the guidelines doesn't mean that it's that or nothing. You can work your way down and then add the non-statins. Add non-statins for cardiovascular outcomes because the data is there, and then the impact on LDL cholesterol lowering, make it make sense in terms of lowering the LDL cholesterol, and then consider upfront mixed combinations. So I do that. I have started moderate rosuvastatin like 10-20 plus an ezetimibe because that's less side effects, but a very similar risk LDL cholesterol reduction. And then consider patient medication burden. This has been the quote unquote sell for a lot of my patients who are every 2 weeks, and I have to refrigerate it, and I'm like, well, it's not an everyday pill, and they're like, oh yeah, you're right, and so they like having at least moving from a once a day pill to twice a month injection. But when you talk to them about, look, this is every 6 months, we time it with our visits or etc., then they're pretty happy to move to the longer acting small interfering RNA.